Hello everyone, welcome back. We're just going to make a start. So very pleased to be introducing abstracts presented by bursary winners. So the UK Myeloma Society awards bursaries for travel to international conferences such as ASH, EHA, IMW, and we've had really high standard bursary applications coming in over the last year or two. So anyone who's involved in research is encouraged to apply. And as well as a travel bursary, you get to present your data at this very august conference. So I'd first of all like to start by asking Martha Ehikioa from Norwich Medical School. She's going to speak to us about multiple myeloma-derived IL-6 reduces fatty acid metabolism in the liver by downregulating CD36 and CPT1A in hepatocytes. Thanks very much.
Well, thank you very much for that introduction, and good morning, everyone. Today, I will be delivering a presentation on how multiple myeloma-derived interleukin-6 reduces free fatty acid uptake in the liver by downregulating CD36 in hepatocytes. Right, there we go. So several studies have shown that myeloma uses fatty acid metabolism via different types of mechanisms. So firstly, I would like to break down a little bit about fatty acid metabolism. So what is fatty acid metabolism? Well, normally, about 90% of your fatty acids comes from your diet, and the rest comes from endogenous sources, so like carbohydrates or amino acids. These fatty acids are then transported to the liver where they can undergo beta oxidation to produce ketone bodies, or they can be converted to triglyceride-bound, very low-density lipoproteins and stored in adipose tissue. If we were to just zoom in a little bit on fatty acid metabolism, I would like to point out one of the key proteins involved in this process, which is CD36. So CD36 is a transmembrane protein, and it essentially allows fatty acids to be transported into a cell where the fatty acid can then undergo beta oxidation to generate energy in the form of ATP. So we know that the liver is involved in fatty acid metabolism, and myeloma seems to use fatty acid metabolism. So the aims of my research project were to investigate changes in liver fatty acid metabolism in myeloma and also determine the mechanistic factors which induce metabolic changes in the liver during myeloma development. So the first thing that I did was I collected blood from myeloma patients and also patients who had hereditary hemochromatosis who were undergoing venesection. I then extracted the blood from these patients, and I used the blood, I applied it to hepatocytes called HepG2 cells, and after a 24-hour incubation period, I extracted the RNA and performed real-time qPCR to measure the expression of genes that are involved in fatty acid metabolism and uptake. And our most interesting finding was the fact that the expression of CD36 was significantly downregulated, significantly reduced in the serum from myeloma patients compared to the serum from control patients. Next, I wanted to see if I would find a similar finding using an animal model. And so for this, I used Caraj mice. So Caraj mice are a strain of mice that have a tendency to develop myeloma. And with these mice, I injected them with a myeloma cell line called 5-TGM1s. And after 21 days, I extracted the bone marrow, the serum, as well as the hepatocytes, as well as the liver tissue from these mice. And then I wanted to make sure that I had successful engraftment of these mice, and I performed a paraprotein ELISA. So with this, I measured the concentration of paraprotein in the serum of the mice, and I found that the 7 mice which had the highest level of paraprotein had a successful engraftment and became my myeloma samples, and the 7 that had the lowest level of paraprotein became my control samples. And using the liver tissue of these mice, I extracted RNA and performed a real-time qPCR to measure the expression of CD36 in the liver tissue of these mice. And what you can see from the graph is the expression of CD36 in the liver tissue from the mice that had myeloma was significantly lower than the expression of CD36 in the liver tissue of the mice that were controls. Next, I wanted to see if I would find a similar finding in vitro, and so for this, I conditioned some media using the myeloma cell line, 5-TGM1 cells, and I placed it on primary mouse hepatocytes. I then extracted the RNA and performed qPCR. And what you can see is, yet again, the expression of CD36 appears to be lower in the primary mass hepatocytes that are exposed to myeloma cells, so 5-TGM1 cells compared to control media. So at this point, we are seeing that myeloma is inducing a downregulation of CD36 genes in the hepatocytes, but I wanted to understand if there was a potential factor that could be able to explain what's happening that I'm seeing. And so I performed the cytokine array using the serum from the myeloma mice and the control mice just to see the different factors that are elevated. And what you can see is interleukin-6 appears to be more significantly elevated in the serum from the myeloma mice compared to the control. And to better quantify it, I did an interleukin-6 ELISA. And what you can see is there is significantly more interleukin-6 in the serum of myeloma mice compared to control mice. So these are all suggesting that myeloma cells are secreting interleukin-6. And research has found that interleukin-6 is a pro-oncogene in myeloma. Interestingly, the Rushworth lab found that myeloma cells secrete macrophage inhibitory factor, and this factor essentially stimulates cells in the bone marrow called bone marrow stroma cells to secrete interleukin-6. So, to summarize at this point, multiple myeloma is inducing a downregulation of CD36 in hepatocytes, and it is also promoting excess interleukin-6. However, I wanted to understand if interleukin-6 could be responsible for the downregulation that you're seeing in CD36 in hepatocytes. And so for this, I treated some media with interleukin-6, and I then placed this on some hepatocytes and measured the expression of CD36. And what you can see is the expression of CD36 is significantly lower in the hepatocytes that are treated with interleukin-6 media compared to control media. So finally, I wanted to understand if the interleukin-6 that is secreted from myeloma cells was enough to affect fatty acid oxidation. And so I performed the seahorse analysis. And so on the y-axis, you can see something called the oxygen consumption rate, which is just a measure of fatty acid oxidation. And you can see that fatty acid oxidation is lower in the primary mass hepatocytes that are treated with myeloma cell and myeloma conditioned media, so the 5-TGM conditioned media, compared to the interleukin-6 conditioned media. And what you can see is the fall in oxygen consumption rate appears to be a similar amount in the 5-TGM or the myeloma conditioned media cells and the interleukin-6 conditioned media cells. So if I were to kind of zoom in just a little bit more, you can see that there is a change. So oligomycin, FCCP, and rotenone are factors that can affect fatty acid oxidation. And every time they are added, they seem to change oxygen consumption rate to a similar degree in 5-TGM conditioned media and interleukin-6 conditioned media that's applied on mouse hepatocytes. So that's basically suggesting that multiple myeloma is inducing the secretion of interleukin-6. The multiple myeloma-derived interleukin-6 alters fatty acid metabolism in hepatocytes. And also multiple myeloma-derived interleukin-6 induces downregulation of CD36 in hepatocytes. So we think that by downregulating CD36 and reducing the uptake of fatty acids in hepatocytes, then there are more fatty acids available that can be redirected to the bone marrow, so the myeloma cells can then use that to generate energy and then fuel processes such as cancer cell proliferation, growth, and survival. Thank you for listening. And
Thank you very much. We've got time for a couple of questions if anyone has anything. Yes, the microphone.
Yeah. Thank you very much for your highly interesting data presentation. But you mentioned IL-6 from myeloma patients, but IL-6 itself probably so has profound effects in myeloma. I'm not an expert here, but what I found that CD36 actually is a negative regulator of angiogenesis. So in myeloma, you usually have increased angiogenesis, particularly in highly active disease. So it might be a physiological counteraction against these myeloma-induced increased angiogenesis. Just a comment.
Yeah, I think that's quite interesting, yeah. I think sometimes what happens is there are different changes that you see in the bone marrow tumor microenvironment compared to places like the liver and such, so sometimes they can act quite antagonistic to each other as well. So while you might see as being upregulated in one, it might be downregulated in the other organ.
And was it stage dependent? So early myeloma versus stage 3 or aggressive myeloma versus MCAS or smoldering?
So what we found was with the Caraj mice that had the highest level of paraproteins, or which were most significantly unwell, they're the ones that had the highest level of interleukin-6. So I think it would be stage dependent with the secretion of interleukin-6. Thank you.
Okay, are there any other questions? Okay, otherwise, I forgot to mention that so Martha was funded to go to EHA. That was funded by the Menarini STEM Lines. Thank you again to our sponsors. And thank you very much for the presentation.
Thank you.
Okay, so the next speaker is Dr. Amrutha Sridhar. She got a bursary award to go to IMS, sponsored by Takeda. So she's going to be talking about disparities in enrollment into multiple myeloma clinical trials by socioeconomic deprivation.
Good afternoon, everyone, and thank you for the UKMS for inviting me to speak today and for their bursary. So today I will be talking about disparities in enrollment into multiple myeloma clinical trials and looking at socioeconomic deprivation and how this has affected enrollment. So a little bit of background. So incidence of multiple myeloma is increasing, largely in part due to an aging population. And we know that there is an increased prevalence in Afro-Caribbean population. In previous studies, there's been demonstrated that there's been disparities in incidence and trial enrollment, which affects overall survival. And a recent paper published showed that there were differences in enrollment according to ethnicity. And this was demonstrated at in a UK centre, which was state-funded healthcare. You would hope for better access to trials. So in this study, we wanted to see whether socioeconomic background also affected enrollment. And the question being, are trials truly informative if they're not representative of the population? So the study was a retrospective data study focused on a single centre, UCLH, and said we aimed to look at the distribution of the enrollment of patients into multiple myeloma trials and looking at social deprivation indices and how this affected it, and also how this affected prognostic factors, how this affected particularly overall survival. So we looked at electronic patient records of patients who were enrolled into studies at UCLH between 2014 and 2023, and split patients into three main cohorts: so early phase trials, the late phase trials, and standard of care therapies. We assessed social deprivation using the indices of multiple deprivation in England, which I'll explain in a later slide. And for reference comparator data, we used NCRAS, which looked at the incidence of multiple myeloma by social deprivation. A little bit about the indices of multiple deprivation. So it's a composite score based on the 7 rankings: income, employment, education, health, crime, barriers to housing and services, and living environment. And they're not equally weighted as per the infographic, but together they give a composite score across all the areas in the postcode areas in the UK. And in terms of ranking, 1 is the most deprived area, and 32,844 is the least deprived area. And initially the data was in deciles, but we were able to transform the data into quintiles so that they were more easily compared to the NCRAS data, which was in quintiles. These are our patient characteristics. We had 580 patients altogether. So what we found was that there was lower enrollment from areas of lower socioeconomic rankings compared to incidence data from NCRAS in both the early phase and late phase trials groups. And we also found that external referrals to UCLH were also chiefly from areas of less social deprivation compared to incidence. according to NCRAS data in England. And in terms of ethnicity, we had a lot more white patients than non-white patients, and in the white patient cohort, we found that that they were from areas of higher social deprivation than their white patient cohort counterparts. And the difference was more pronounced in the late phase trials groups than in the early phase trial groups. And so just a quick visual representation of the flow of patients, and as you can see, we had a lot more white patients than minority ethnic groups, but also in terms of the flow of patients, we had far fewer patients into the fifth quintile, which was highest deprivation, as opposed to the first quintile of least social deprivation. And furthermore, we found in the late phase trials groups, the overall survival was significantly different in the lower socioeconomic group than in the higher socioeconomic group by an order of about 3.5 years. We didn't observe this in the early phase trials group. In the looking at the overall survival of white patients, we found that white patients in in areas of higher social deprivation did much worse than from areas of lower social deprivation, but we didn't observe this difference in the non-white patient groups. And in patients aged over 75, we found that social deprivation drastically reduced overall survival by about 11 years, whereas we didn't see this in the less than 75-year-old patient group. So, pulling this data together, as said before, we noted that there were disparities according to ethnicity, but also socioeconomic class affects access and overall survival of patients. Patients enrolled into clinical trials at the UCLH were from less socially deprived areas compared to NCRAS incident data. But also, importantly, we noted that there were skewed referral patterns in that a lot more of our external referrals were from areas of low social deprivation compared to patients from areas of high social deprivation. We found that social deprivation does negatively impact overall survival, and it was much more significant in the white patient group and in over 75-year-old patient groups. However, we did have low numbers in the non-white patient groups. Enrollment into clinical trials should ideally be monitored by socioeconomic distribution so that we have good and fair and adequate representation of our patient groups. Our limitations of our study were that it was a single-center study, and also aggressive disease, late-stage presentation must also be considered in terms of analyzing overall survival, and postcode doesn't necessarily fully reflect socioeconomic class. Future explorations. So an important thing to look at would be what caused the skewed referral patterns and what can we do to increase access to clinical trials across all socioeconomic classes, and what can we do to increase trial access and engagement for patients of ethnic minorities as well as deprivation. Interestingly, there was the much worse overall survival in the patients aged over 75 years old in the setting of social deprivation, and it would be good to look at the factors driving that and what we can do to mitigate this. And also the factors driving the overall worse survival in white patients in the setting of higher social deprivation. And thank you to UCLH, the Clinical Research Facility and the Clinical Trials Unit, and my co-author, Selina Chavda, who couldn't be here today, and the team at UCLH.
Thank you very much. Are there any questions from the floor? There's one over there.
Thank you. That was a really interesting talk. I'm wondering how much of this can be put down to challenges with health literacy, challenges with language barriers, and perhaps also access to clinical trials across the UK, because there are disparities even in terms of that, rather than just around socioeconomic status. So, have you looked at any of this, and what do you think is probably driving it?
That's a really important point, and certainly on the aspect of language barriers, I know some studies, there's more work being done to increase the number of languages in which the information sheets are available. I think there needs to be more work done in terms of looking at the reasons behind lack of access, barriers to access, essentially. At UCLH, we're very accessible in terms of transport links, etc., but there's a cost burden of traveling to London for frequent follow-up and treatments, and that's something that we're looking at as well.
Do you also think it might be driven by trust in clinical trials in general? Because there is evidence of that.
Yes. Yeah.
And how, I guess the big question there is, how do we overcome that?
Mm-hmm.
Because I think it's a bigger problem than necessarily just being in haematology.
That's a really important point. It's definitely, and in the previous study where they were looking at differences in enrollment by ethnicity, trust and mistrust of healthcare professionals was an important point that was raised. And I think you're right, it's a problem beyond haematology as well, and I think all specialties do need to work together to see whether we can tease out the reasons behind it and what can be changed to improve access to across healthcare, not just to trials.
Okay, thank you very much.
Thank you.
Oh, sorry. There's one question here.
Thanks. Just to answer some of that question, so we are going to be looking at that within the UKMRA. We have an equality diversity group, and we're going to start trying to tease out some of these very complex issues. This is just one element of a very big complex story, and hopefully over the next few years we can start to make a change.
Oh, sorry, there is another question here.
Trying to make a quick escape.
The other thing I think you need to look at is referral for trials proportional to the number of staff in haematology in each trust, because there's such disparity in the number of staff that are available on sites. And I think that's something we need to take slightly more seriously in the UK.
Yeah, absolutely. Thank you.
Any other questions on that talk? Otherwise, thank you very much, Emma. Next, we have Dr. Dan Hughes, also from UCLH. He was awarded an IMS bursary by Amgen. He's been talking on smoldering myeloma.
Hi, I'd like to thank everyone for being here, and thank UKMS for having me speak, and UKMS and Amgen for the bursary. I'll be talking about data from the UK COSMOS study in smoldering myeloma. So just a bit of background to start with. Myeloma is preceded by the asymptomatic precursors, monoclonal gammopathy of undetermined significance, and smoldering myeloma. Smoldering myeloma is a heterogeneous condition with biological behaviour ranging from essentially MGUS to disease in evolution to myeloma. There's significant interest in the treatment of patients who will progress prior to the development of end organ damage that may be permanent at progression. And we do have some risk models in smoldering myeloma to try and determine those at high risk of progression, but they're largely based on disease bulk and cytogenetics as a single time point, and remain imperfect at distinguishing people who will progress at 2 years. So the COSMOS study is a prospective observational study in smoldering myeloma in the UK. We've been open since 2021, and we're aiming to recruit 500 patients with smoldering myeloma. We have follow-up of and collection of routine clinical information, routine laboratory data and imaging, as well as regular sampling of peripheral blood and bone marrow. Patients followed up for 5 years or until progression, and with prospective and sequential sampling, we hope to track changes in tumour genomics, bone marrow microenvironment, and serum biomarkers. So first off, looking at the baseline characteristics, in September 2023, we had recruited a total of 202 patients, 20 of whom had myeloma based on initial investigations, so were kind of excluded from the remaining analyses that are there. The data overall is pretty consistent with what we might expect. I'll kind of point out that we recruit anyone with a diagnosis of smoldering myeloma, so they can have that established diagnosis, and the median time from diagnosis to entry was 10.5 months. We have low rates of withdrawal. In the table on the right, we have some of the risk characteristics, looking at the kind of most commonly used risk scores, the 2220 and the IMWG. The UHR there stands for ultra high risk and is those meeting SLIM criteria who are being monitored. So we have 30% of patients who are high or ultra high risk and 6% who are intermediate or high risk. The cytogenetics given there are from clinical FISH, and that is kind of limited by the probes that are used, which probably explains the lower rates of hyperdiploidy and del13Q that we're seeing. On all bone marrow samples we receive, we run a basic immune core panel, and this is just looking at some of the entry clinical data and immune data that we have. So at baseline, bone marrow plasma cell percentage correlates positively with serum markers, paraprotein light chains, as we might expect, negatively correlates with hemoglobin. Albumin negatively correlates with markers of disease bulk, whereas LDH and beta-2 microglobulin don't consistently correlate. Light chain ratio and bone marrow plasma cell percentage were higher in those with immunopoiesis than those without. And then looking at the core panel, the Tregs had a trend to decrease with increasing 2220 risk group. Evolving disease is a known risk factor for progression in smoldering myeloma. There's a few different definitions for evolving disease out there. We've picked one by Ravi et al. 83 patients were evaluable, 23 patients met criteria for evolving disease, so just under 30%. 20 of those had an evolving hemoglobin, 6 had an evolving paraprotein, so 3 with both. There was a numerical trend in the entry data for an increased bone marrow plasma cell percentage and paraprotein, but not light chains, as well as core panel NKT cells. There was no difference in the T regulatory cells despite their association with the baseline 2220 risk score. Analysis at the moment is limited by small numbers, but we feel this is an important group to closely track. Looking at those who have progressed, so in total, 32 patients have progressed at a median of 13 months from diagnosis. They're shown in the swims plot on the right there. The kind of blue bar is their times from diagnosis, not on study, and then in red is their time on the Cosmos study. And where we have information, we've added kind of symbols to mark their imaging and bone marrows. The reasons for progression are shown in the table in the bottom left, and important to note that over half had bone disease at progression, which is important because the associated morbidity, which we heard a lot about this morning. Of the 32, 20 had progressed at entry or within 3 months, so 12 people who progressed whilst on study. They were at a median of 10.5 months from study entry and 21.5 months from diagnosis. The reasons for progression in that group were very similar to the total cohort. So looking at ongoing work, we are continuing to recruit patients. We're open at 18 sites across the UK. In addition to the baseline immune core panel we have at the moment, we've established panels for NK and B cells. There's more detailed immune phenotyping going on with cytoff in T, NK and B cells. We're looking at sequencing of tumour and immune subsets to examine potential intrinsic, extrinsic relationships and looking at spatial relationships with immunofluorescence staining of trophines. And we're also looking at potential serum biomarkers in circulating tumour cells. So to conclude, prospective recruitment and longitudinal sampling in smoldering myeloma patients is feasible. In this interim analysis of 202 patients, 30% are high risk. Entry bone marrow plasma cell percentage seems to negatively correlate with hematopoietic reserve Albumin negatively correlates with disease bulk, but LDH and beta-2 microglobulin don't appear to be particularly good disease markers in smouldering myeloma. Univariate analysis of broad immune subsets doesn't appear to inform of risk of progression, which indicates the ongoing need for our in-depth phenotyping, multivariate analysis, and dynamic modelling. And I would just mention that there's an interventional trial in intermediate and high-risk smouldering myeloma patients that's in the process of being set up, and COSMOS will enable indirect comparison of treatment versus observation in UK patients with smouldering myeloma. And with that, I'd just like to finally thank the UKMS and Amgen again for the trial bursary, CR UK who funds the COSMOS study, all our site PIs and trials teams and patients, as well as the CI and CI Kui-Yong and Karthik Ramasamy, and then all the people at UCL who process the samples. Thank you.
Okay, thank you very much. Are there any questions on that? I mean, I guess I've just got one sort of general question on smouldering myeloma cohorts. It's not like myeloma where patients are symptomatic, and it's not like the iStop study where you've sort of done screening. So do you think there's a difficulty comparing cohorts of patients with smouldering myeloma now, where there might be more awareness, because they might be picked up at a relatively earlier stage, whereas in the past there was less awareness, so people were picked up at different points? Do you have difficulty comparing your data set with others?
So I think that there's certainly some difficulty in that, I guess, especially where we're enrolling anyone who's got a diagnosis at any time point, I guess, comparing those who are de novo diagnosed with who've had a diagnosis for several years. I think that it's tricky to apply risk scores to people who've had disease for several years, particularly if you know they've been stable, and compare them to people who are just diagnosed. But I think that the kind of longitudinal sampling and seeing the changes over time is going to be the key thing that COSMOS allows us to do, which hasn't been done so much previously.
Thank you. Any other questions? I think there's one at the back, sorry, thank you, and one more in the middle afterwards.
Yeah. So I may have missed this, but did you show correlation between those who progressed with the 2020 classification or even with the cytogenetics? It's quite interesting for you to see so many high-risk cytogenetics in this sample, right?
Yes, so at the moment we have quite a small number of patients who've progressed on study. The majority of those were high risk by 2220 classification. We're kind of unfortunately struggling with getting cytogenetic information for all the patients, so even smaller numbers there, too few really to make any comparisons at the moment.
Thank you.
And there was just one more question here on the gentleman in the third row.
It's a great study. I just have a feeling that you won't be able to see the chief from the chaff until you've got most of your patients out to 5 years, because some of them are actually MGUS, aren't they? And they're not going to progress, and their risk will fall away if they've not progressed in the first 5 years. So some of your analyses and some of your distinguishers may only peak their head above the parapet when you've got most of your patients out to 5 years. Would you comment on that?
Yeah, I think that's very true. I certainly think that it's going to take longer for us to get more progressors and more patients with stable disease to make any definitive conclusions from the study. So I think we're starting to get to the point where we are getting more progressors, particularly the high-risk patients progressing, and so we might have some of that information coming soon, but I think it will take time to get that more definitive information.
Okay, thanks very much. Thank you very much, Dan Hughes. And our final bursary winner is Dr. Ed Watson from the University of Oxford, who's speaking about real-world outcomes of belantamab monotherapy. And this was a bursary that was sponsored by Janssen to go to IMS. Thank you.
Hello, and yes, and thanks for having me, and thank you very much to UKMS and to Janssen for the opportunity. It was a great thing for me as a sort of budding clinician scientist person to attend IMS. It was good fun, I think it was also quite good really just to represent an abstract, about 25 different contributors, so it was good to represent their work. It's nice to have a captive audience here rather than sort of the people who sort of wander past a poster by accident. I think in terms of conflicts of interest, the one thing I would actually say is my PhD thesis currently is on single-cell response to belamaf, so it'd be quite nice if it stayed relevant for a little while longer. But there's a lot to learn from it, however it all pans out. And I hope you don't mind me, forgive me for starting with just sort of my model and where my starting point would be sort of conceptually. If we look at locomotion, which is, I think, a neat prospective approach to understanding where sort of the state of play, 250 patients, mostly European, who had 75% of whom were triple-class refractory, and who did have a pretty upsetting prognosis. And for me, kind of the standout stat was the fact that sort of there were 91 unique therapies used across these 250 patients, and you could either see that as a triumph of personalized medicine or maybe sort of running out of ideas, and it's certainly the case that cyclophosphamide was the most prescribed, 32% of patients receiving it. So it's true that it stopped recruiting in October 2020, and so that just before the wave of immunotherapy that we're so familiar with now. But I think it's still quite relevant to UK practice, as far as I understand it. Really, outside of a clinical trial, the only immunotherapy we can access for our patients currently is talquetamab and belamaf. And so I do think we certainly can go forward with this group and understand a little better. So belamaf then, it's a IgG antibody targeting BCMA, that's the belantamab part, and the mafodotin is obviously the auristatin payload. It's killing cells directly, therefore, by apoptosis, but it's also recruiting innate and adaptive immune responses. So described 2014, registration for DREAM2 began in 2018, and the sort of first report came out in 2020. So it's a pretty heavily treated cohort, a reasonable amount of high-risk disease there. And the responses were modest. But I would draw attention to the DOR I thought was interesting. And the keratopathy as one of the adverse events that we're now quite familiar with as a concept, that clearly was very clearly highlighted by the trial. But there was sufficient information to suggest that we should at least conditionally be using this drug. And in the US and subsequently in Europe, this has happened. DREAM3 has read out now, and we haven't seen superiority against PomDex. So withdrawal of the license in US, and as we've heard in Europe, the ongoing discussions about it. Nonetheless, at the moment, we can still use belamaf on a sort of named patient program in the UK and Ireland, and that's the context in which we studied all of this. So this was our study, so it's a real-world study. My PI hates that phrase. Where else do we all live? It's named the named patient program. All patients who were enrolled in about 13 different centres across the UK and Ireland, data was sort of submitted on electronic form across several domains, and sort of registration of cases was through from sort of early 2022 till June 2022, with Oxford actually sort of extending registration through. And then we revisited these patients in the summer, well, September really of this year. So we've got a median follow-up by Kaplan-Meier of about 17 months. I just sort of draw attention really to the issues with data completion. It's a pretty sizable form, requires a lot of time, and these are clinicians, these are people working, trying to fill these in. And on top of that, of course, it's real world, and there's so many data gaps. So that definitely is the limitation of the study. In terms of the group of people we were working with, or we were sort of seeing come through then, so a relatively highly treated population, but perhaps slightly lower risk than we're seeing in DREAM2. So relatively young, not too many comorbidities, perhaps. But in particular, I just sort of the disease, obviously it's very hard sometimes in retrospective data in particular to collect ISS status, to collect cytogenetic status. So there's a lot of absent data, but potentially lower, sort of underrepresenting the high-risk guys in our cohort potentially. And slightly weirdly, given the SPC, 10% of our patients hadn't seen an anti-CD38. I don't know how they snuck through. So on the response side of things then, so the headline is 56% overall response rate. You see the breakdown there on the left, and in figure B, trying to work out sort of, which subgroups are going to do particularly well. There were no obvious sort of standout groups, and that's sort of been the case throughout DREAM2 and throughout the other real-world data sets that are out there. But I would just point out in the ocular toxicity, so that's that very top part of panel B, you can see there's potentially a trend to those who have higher toxicity maybe have slightly better response, and that, maybe that speaks to the pharmacodynamics of it, maybe that speaks to bravery of clinicians just pushing on, or bravery of patients, I suppose, just pushing on with treatment. But that's something that just stuck out. And then otherwise, it's sort of translating to what that means survival-wise. For me, again, the take-home is the median DOR. We haven't got the upper limit of that confidence interval, despite 17 months of follow-up. But we're seeing 23 months, which is not insignificant. And the PFS, quite a bit better than DREAM2, as is the median overall survival. Obviously, better being entirely non-statistically used. Just want to focus a little bit more on the ocular side effects, because clearly that's what people, understandably are sort of interested in at the moment. And if we use DREAM2, in DREAM2 they reported them as keratopathy, visual blurring, and dry eye. So keratopathy being sort of an ophthalmologist's opinion, having done a formal examination. Visual blurring and dry eye, obviously, potentially more symptomatic related, symptomatic type, and reporting in our retrospective thing may completely miss that. So whether A actually truly reflects the distribution, it's not clear, but certainly keratopathy was common. I feel like I've missed overall tox. Let's talk about this. I feel like that skipped. I don't know what happened. So fundamentally, keratopathy is the most common, and that's similar to DREAM2. But I would just point out that the chest infection and COVID, between them, accounted for sort of obviously the most morbid, the most severe disease. And in fact, chest infections trump everything else in terms of grade 3 to 5. And I think that's something that we shouldn't lose sight of. But keratopathy, clearly a very commonly experienced process. And now let's talk about keratopathy and eye conditions. And in terms of what we try to look at, baseline conditions, so cataract, dry eye, glaucoma, blepharitis as well, although it turns out we had no one with blepharitis, or it wasn't coded, so we couldn't find anything out about that. But in terms of cataract, dry eye, and glaucoma, it didn't appear to necessarily predict your risk of having an eye condition of some eye complication of some sort. The numbers are relatively small. The only thing is that if you had pre-existing dry eye, you were more likely to get visual blurring symptoms than otherwise. Figure C is deliberately a bit much, but what it is that's 44 patients for whom we have serial keratopathy monitoring. And you're just seeing a trend in keratopathy state over time. The circles suggest that a patient was then given treatment at that keratopathy grade. Across would mean it was withheld. I've just boxed in yellow, just for your interest, the total number of patients who had a grade 2 but were nonetheless treated. I just think it's interesting, if they were on DREAM2, as far as I can tell, that wouldn't have happened. The guidance is that you would hold and wait for that to drop back down to keratopathy level 1. So perhaps there's a bit more tolerance for prescribers and presumably for patients, and a bit more pragmatism in the real world. And then going forward, just thinking a little bit, I think there are two powerful things here. So one of them, we've got to leverage the heterogeneity that we see in the study. So our study there in pink appears to show a change in, is statistically different, it seems. There's heterogeneity if you look at all the real-world studies. Why is that? Why do our patients seem to do, slightly better? Could just be a fluke, but the stats would suggest there may be something in it. And then there's heterogeneity, as far as I can tell, within a trial. The fact that you have a DOR of 12 months or so median, which compares to a PFS that's quite a lot lower than that, suggests that there is a sub-cohort somewhere that's doing quite well. And we just need to try and find out who they are. And at the moment, as far as I understand it, we don't have too many clues on that. And then the other thing we need to try and do, I think, is improve the tolerability, and the focus a lot of the time is on keratopathy. And just as an example, in Greece, they are running a trial where they're using 8 weekly belamaf. And unsurprisingly, the keratopathy and the ocular disturbance is a lot better. So leave it at that, really. And thanks to very much everyone, and thanks again to UKMS and Janssen and for the chaps you see listed there, and everyone who collaborated, of course, without whom there would be no project. So thank you very much.
Thank you very much. We've got time for a couple of questions on that, if there are any. Any hands? I've just got a general point. I mean, we've used some, as you know, we've also used belantamab, and I think with dose reduction and sort of good consultation with ophthalmology, it is deliverable. But do you think this is something that will be practical to be rolled out to the country from when NICE ever did it, or is it just going to be too fiddly to use in practice in sort of a smaller centre or a smaller DGH?
Yeah, I think getting hold of the ophthalmological input is a real limiter. I think we struggle. We've got an eye hospital, not far away, and we were eating into like clinical trial slots to get patients seen by ophthalmology. I think if you're going to drop the dosing intervals, then that would potentially take the burden off. But that would obviously need an evidence base to kind of make that decision.
Sorry, Kerry.
Thanks, really nice talk. Do you have any data on characteristics of people who don't respond to belamaf? And is there any link between BCMA expression, or is that not known?
So at this granularity, not really. I mean, the swim plot, just shows us, the people who don't respond pretty quickly. Where was it? So I think that's the guys in yellow. It's all very, it's pretty quick. We don't have. There's no obvious breakdown as to who's going to badly respond, as far as we can see. Hopefully, during my PhD, I'll try and find some of that out, but not yet.
So it might just be really bad disease for us.
Yeah, absolutely. I think that definitely has to be. That has to be in it. Yeah, it has to be in the mix.
I could just like Rakesh, actually, I think the PROMISE trial is that using belantamab without ophthalmology input. Would it probably be useful just to know what the route might be to sort of delivering this drug without having dedicated ophthalmology clinics, because that's something that would be of interest.
Thanks for that. So I completely agree, ophthalmology is a bit of a pain for everyone. So we, along with Evangelos Terpos, whose trial you mentioned, are looking at a non-ophthalmology way of dosing belantamab, where we will be giving a questionnaire to patients which will give us an indication of visual acuity and keratopathy. So that study is in development, and we hope, looking at my Leeds colleagues, that will open next year, the second arm for that. And we do give belantamab every 8 weeks. And hopefully, if we combine both of our data sets, then we can make a change in the way belantamab is delivered. So do recruit patients, send them to us. A little plug for the trial.
Okay, so thank you very much to Ed. I'd like to thank all of our abstract awardees for their presentations.
So thank you. We're now moving on to the Michael Morley lecture. I just want to quickly talk about Michael Morley. So Michael Morley was a patient with myeloma who sadly passed away many years ago, and his family very kindly donated a fund for us, which supports eminent speakers to come and talk to us. Also supports some of our trainees to go off to conferences and things. So we're eminently grateful to the Michael Morley Foundation for their support. So it's really, we always have eminent speakers, and we really do have an eminent speaker today. So Heinz Ludwig is a professor of medicine and hematology from Vienna. His main focus has been on myeloma therapies and also anemia of cancer. He has an extremely impressive CV. He's been involved in clinical trials. He's been a member of the International Board of ASCO, president of ESMO. He's on the International Myeloma Foundation board. He was on the chair of the EMN, European Myeloma Network. He's president of the Australian Forum Against Cancer, and he very impressively got the Bob Kyle Lifetime Achievement Award. I think we're really honoured that you've come to talk to us here at the UK Myeloma Society Michael Morley Lecture. And his title of his talk will be Managing Infections in the New Era of Myeloma Therapies, Prophylaxis, Monitoring and Treatments. A true honour. Thank you.
So, thank you very much, Dr. Arvin. for this kind introduction. Thank you for all of you listening to my presentation, and thank you to UK Myeloma for inviting me, Dr. Sive, who started the process. I'm pleased and honored to be here with you and to speak to such a distinguished audience. So the topic is on the first slide. These are my disclosures. We all know that myeloma patients have many factors which contribute to their increased risk for infections. First of all, myeloma-related immunosuppression is key, particularly in those patients with advanced, uncontrolled disease. Then we have myeloma therapy, and that is one of the major topics of today. Advanced age, of course, and myeloma and therapy-related morbidity. And of course, men are discriminated, or as usual, because female patients have a lower risk for infection, 20% lower risk for infection in general. This has not been shown for the new drugs, I must say. Now, when you look at the different alterations in the environment, in the bone marrow environment of our patients, you see here that actually every cell type, lymphocytes, dendritic cells, endothelial cells, and cells involved in bone formation may be impacted by the tumor and may also be instrumentalized to support myeloma growth, like, for instance, an increase in T regulatory cells, an increase in myeloid-derived stem cells, which all push myeloma to increase proliferation and becoming more and more aggressive. Now, when you look at the general landscape of bispecific antibodies and the risk of infections, which is shown here in this line, you see here that the risk for infections varies between 34 and 67%. And in the lower line, you see the risk of grade 3 and higher infections, which is shown here. And of course, you have this enormous, let's say, suppression of hematopoiesis. You have leukopenia, neutropenia, thrombocytopenia, and lymphopenia, particularly, of course, is responsible for hypergammaglobulinemia, which should be here, which is not reported here for all studies. So that is now actually a new scenario. We have dealt with infections all the time until now, but this is really new because the impact of these novel treatments on the immune system are, of course, much more severe than they were before. And when you then ask the question, when you meta-analyze all the evidence which is available, you see here the risk for infection is 65%, and the risk for severe infection, grade 3, 4, and even grade 5, is 24%. And there are data showing that, of course, if you use, and that is true for bispecific antibodies or CAR T cells, if they target BCMA, the effect on lymphopenia is much greater than when you target non-BCMA epitopes on myeloma cells. And in here you see the difference of grade 3 and higher infections is significant. And in some studies, it's even more impressive, the difference between BCMA and non-BCMA targeted therapy. When you combine now bispecific antibodies with a CD38 antibody, you increase the risk for infections because CD38 antibodies per se already are associated with higher infection risk. And here you have this data, median risk for infection, 71%, grade 3 and higher infections, 26%. And when you try to maximize the potential of bispecific antibodies and combine two different bispecific antibodies, you get a higher, much higher response rate, up to 80% in relapsed refractory patients. but you also have to deal with a higher infection risk shown here, and the infection risk for grade 3 and higher infections is more than 50%. So the increased effectiveness comes with a significant price. But when we compare all these studies, we have to acknowledge that we have to look very carefully about the report. How long was the follow-up? But when you look at these figures here, you see that is the cumulative incidence of bacterial infection. And it depends very much when you report your study at this point of time or when you follow your patients much longer. But that is not, let's say, clear from all the comparisons. So we have to be very careful in looking at individual numbers, because we should change our way how we document or how we present the risk for infection. My suggestion is to present the risk for infections, for instance, per year treatment or per year observation, in order to eliminate this bias, which is given by the different lengths of observation of individual studies. But what is clear here is the longer you follow your patients, the higher is the risk for infections, bacterial infections. And what you see already here, and that is shown with CAR T cells as well, initially you have more bacterial infections, but then viral infections come up. And of course, there's a risk for fungal infections. And here at different time points, we have these different figures showing the longer you follow your patients, of course, the greater is the risk for infections. Now, and that is data for patients who have been treated with CAR T cells. Here, the scheduled areas are those with grade 3 and higher infection. And again, and here you see it more clearly, the difference of BCMA targeting CAR T cells as compared to GP receptor C5T targeting CAR T cells. Is huge difference between the infection risk between different CAR T cell studies. Now, of course, in CAR T cell therapy, you have already, your patients are up to now handicapped because they have been pre-treated, have several lines of therapy. But I must say, we can discuss it later, studies pushing CAR T cells in first-line therapy have already been started. And for instance, the trial, the CARTITUDE-6 trial, compares CAR T cell therapy as first-line treatment with stem cell transplantation. And so probably those patients will have lower risk for neutropenia or cytopenia. But then you have these T cell lymphocyte depletion, and then the hematopoiesis is handicapped, and you see here the increase in cytopenia, and I think in yellow thrombocytopenia, neutropenia, and so on. And again, here you have on this side the resulting infections, bacterial infections, viral infections, and fungal infections. Now, there are several scores. One of the most attractive scores, in my opinion, is the so-called CAR T cell hematotoxicity score, which just uses 5 parameters: platelet counts, neutrophil counts, hemoglobin, C-reactive protein, and ferritin. And then it's all available on-site as a web tool, and you can then enter the parameters of your individual patient, and then you get a risk score. You get the risk score, and if the risk score is 2 or higher, then the patient is considered to be at high risk for hematotoxicity, including infections. And when you look at these patients are patients here with a high risk score. Those are patients with low risk score. And you see here, those patients, of course, with high risk score remain much longer aplastic, and quick recovery of hematopoiesis is much better in patients with low risk. And here you have the data of individual patients showing the difference between high and low risk patients according to the hematotox score. And then you ask the question, what are the infections which we have to cover, which we have to cope with? And in the beginning, you have here bloodstream infections, so you need to look and monitor CRP, of course. You have upper respiratory and lower respiratory tract infections, and here upper and then lower respiratory tract infections, GI infections, urinary tract infections. Then you have skin and soft tissue infections, and some patients, unfortunately, develop central line infections. So the lower respiratory tract infection is usually the consequence of a viral infection, which is a door opener for bacterial infections later on. And when here you have, again, the difference between patients with high score, they have much more severe infections in general, and infection-related mortality. And these are infections in general, and here you have infections due to bacteria, a similar picture. And again, here you have the cumulative incidence rate of infections and of severe infections. When you have a high hematotoxicity score, you have a higher risk for ICANS, and you have a shorter progression-free survival and shorter overall survival. Now, here you see what we have already shown to some extent. The pattern of infections changes after CAR T-cell therapy. In the beginning, you have much more bacterial infections as shown here, but these are infections until day 100 after CAR T-cell infusion. And later on, you have more viral infections, and here you have the different viruses, and pneumonia, no otherwise specified. So it's a changing pattern, but of course you have infections also later on, as shown here. So what can we do? Our present means are rather a little limited. That is my personal perception. But we have, of course, vaccines. We have IV immunoglobulins, growth factors. I will not talk too much about growth factors. We have antiviral, antifungal drugs, antibacterial drugs, and of course, general measures which we should not forget. We should not forget those. Now, I think when it comes to myeloma and the myeloma patient addresses you, I think, in my opinion, there are 4 must-haves. A myeloma patient should be vaccinated. I know it's easier said than done in the practice. He should have vaccination against influenza, pneumococci, no question, herpes zoster, and COVID virus. And of course, we all know that myeloma patients, and particularly those with ongoing disease, with active disease, have reduced immunoreactivity against antigens, vaccines. So it's recommended, but it's difficult to do it in clinical practice, to either check the antibody response or more easily to use to give the patient 2 doses of a preferentially quadrivalent influenza vaccine. Then you have pneumococci. You start with a conjugated vaccine, and then after 3 to 6 months, you follow with a polysaccharide vaccine, and you may use 1 or more doses. And here we have now the Shingrix for herpes zoster, 2 doses, and of course SARS-CoV-2. And actually we have now these new adapted vaccines, which are adapted to the Omicron variant XBB 1.5. And you have one vaccine from Pfizer and the other one from Moderna, so you can choose between both. I can tell you I had my shots on Monday this week and tolerated very well. And together with influenza. So yeah, you can do both together. So that's a good side. And there's something which we have to consider in the future, because we have a new vaccine. We all know that respiratory syncytial virus is a big threat for elderly, for frail patients, also for children. But now there's a new vaccine available. It has been approved in the US. It is approved in Europe. And actually, I also received this vaccine and I tolerated quite well. So in this respect, I may be a role model for our patients, but that's the only one. But you see here, and we don't have data in myeloma patients. That is our problem. But when you look at the general population, patients who are individuals who are vaccinated, they do much better. The risk for getting RSV infection is much lower. Vaccine efficacy is 95%. These are the placebo patients. So in the future, we'll probably add this. The problem with myeloma is we should have prospective randomized trials, but it's very difficult to do this. And so we do this by just drawing analogies. But I think we are not wrong when we draw analogies here in this field. Now, what else can we do? We have here, that is particularly relevant for patients with asplenia or with reduced spleen function, for instance, due to amyloidosis. These are maybe candidates for Haemophilus and meningococci. And then we have hepatitis A and B. That is relevant for patients who live in countries where hepatitis is endemic, but hepatitis A, I think, is a must for normal people as well. Hepatitis B, diphtheria, tetanus, and pertussis, again, relevant for people in living or traveling to areas of high endemicity. And mumps, measles, and rubella needs to be very carefully considered because these are attenuated live vaccines. And when you consider to re-vaccinate your patient after CAR T-cell therapy, you should assure that he is, again, immunocompetent. Otherwise, you should not use these vaccines because of the life-attenuated nature of these vaccines. Now, that is also easy said, but more difficult to execute in clinical practice. Actually, we should vaccinate our patients during MGUS or smoldering myeloma status. That is the best, of course, or before therapy, before aggressive therapy. If this is not possible because the patient has already a long-standing history of myeloma during phases of well-controlled disease in remission, during periods without therapy. If the patient is on land maintenance, there are limited data that it may even augment the immune response. But this is very weak evidence. And you can, and then it's a question of what do you do, for instance, with COVID. Now it's easier, much easier. But a year ago or 2 years ago, myeloma physicians ask the question, what shall I do? My patient is not in remission. He has active disease. Shall we vaccinate or no? And I must say most of the colleagues I was asking agreed, said, yes, in spite of these limitations, we prefer to vaccinate our patients. And of course, it's not only the patient, it's a care team. We all should be vaccinated, and all nurses should be vaccinated, and of course, the household members should be vaccinated. Now let's switch gears. Now we come to antibiotic prophylaxis. And we are pleased that Dr. Bokop, who is chief investigator of this important study, which was published 4 years ago, is here in the audience. And the data are very important for all of us. What did they do? They used, they randomized closely 1,000 patients, but these were patients with newly diagnosed myeloma. So it's probably not comparable to patients with end-stage disease. Randomized the patient to levofloxacin for 500 milligram per day for 3 months or placebo. And we have to acknowledge that 14% of those patients received in addition Bactrim, or as you want to say, sulfametaxazole, trimethoprim. And this in this group, 21% had these prophylaxis. But what was the endpoint? The endpoint was feverish episodes or deaths within the first 3 months after start of therapy. And this was a very positive study. You see here, infection and mortality was significantly decreased by prophylaxis. And when you look at mortality, there was a significant improvement in reduction the risk for mortality in the prophylaxed patient. And the people were very, let's say, some of those patients are very critical because there is, of course, the fear that you may induce resistant bacteria, but this comes a little bit later. So when you look at the details of the paper, you have a significant reduction of gram-negative infections. With Bactrim, you have a significant reduction in both arms, and particularly regarding gram-positive infections. And the benefit was greatest in frail patients, in elderly patients. So this is the patient group we should focus on. There was no difference between both arms in infections with these pathogens. And there was no evidence, and that is, I think, remarkable, for induction of antibiotic resistance. And these are the sites of infection. So very positive, but this was newly diagnosed patients, and we now have to tackle, we're talking about heavily pretreated patients. But there are other studies, prospective randomized studies, comparing antibiotic therapy with placebo. And here you see, of these, I think, 5 studies, 4 were positive. Here we have this, actually, and only one study did not show a benefit for antibiotic prophylaxis. But these were the old times where chemotherapy was used or transplant was given. So it is not so easy to draw analogies with our present treatment and future treatment scenario with bispecific antibodies and CAR T cells. Now, and now let's move to hypogammaglobulinemia. Of course, what shall we do? Clinical practice, we test for IgG levels, IgA levels, IgM. We do not test, at least in our department, we do not test for antibody response in those patients against virus or bacteria because the patients have impaired antibody response. So we prefer to use PCR technology when we suspect an infection or when we want to capture reactivation of CMV or EBV. So that is what we are doing. Who should be treated? There are some guidelines. And actually, the guideline says you should start treatment in patients with IgG levels below 400 milligram. But that is not, I think, the holy grail, because there may be patients which have higher IgG levels but have recurrent infections. So I would include those. So the history of an individual patient, if the patient comes in with a history of several infectious episodes before starting bispecific antibodies, I wouldn't care about the IgG level. I think those are patients who should also receive prophylaxis, but this is my personal opinion. Patients with life-threatening infection, patients with documented bacterial infection, with no insufficient response to antibiotic therapy. So that should be done. And is it, and how frequent is the incidence of hypogammaglobulinemia? It's particularly frequent in patients, again, receiving BCMA-targeted bites, or bispecific antibodies, as you see here. And the incidence is slightly low, or is significantly lower in patients receiving CAR T cells. And the IgG levels decline with increasing duration of administration of bispecific antibodies, as you show here. And the question which is relevant for all of us, does it really matter if we supplement IgG in those patients? There are very few data. The most important data have just recently been published. This is from the Majestic-1 trial, and Niels van der Dok has presented this data at the International Myeloma Society meeting in Athens. And here, that is not randomized. But these were patients with low IgG. Half of the patients received IgG supplementation, and the other one not. And here you see the risk for infections, which is significantly reduced with IgG replacement. So actually, that is what is done now in clinical practice. Now, when we look at certain international societies and their recommendations, we have talked about antibacterial prophylaxis. I'm not going to talk about GCSF. That is evident that patients should receive GCSF. The question is, if the patient is completely aplastic, I'm not sure whether it's really helpful. And then pneumocystis jirovecii, of course, that is more or less agreed by all societies. I will show you data thereafter, that those patients who are subjected to CAR T-cell therapy should receive prophylaxis with Bactrim, and antifungal prophylaxis depends on the leukocyte count and the amount of the duration and the dose of glucocorticoids, and here you can use respective prophylaxis. Now, the question is, do all individual societies come up with the same recommendations? Do you expect that? When you look at this data, the answer is clear. When it comes to bacterial prophylaxis, there is a recommendation for active prophylaxis in patients with neutropenia. That comes from Fred Hutch from Seattle. Dana-Farber, Boston, recommend this treatment, and I think the University of Munich. But then when it comes to, what is this here? Antifungal prophylaxis, fluconazole to prevent infection by Candida, and posaconazole to prevent infection by Aspergillus and the related species. You see here some heterogeneity in the guidelines which have been published. That is not true. The only exception is here 3-metoprim sulfamethoxazole prophylaxis against pneumocystis carini. Viral prophylaxis, there is also a clear homogeneous statement that we should do this. I think everybody is doing that, and that is without doubt. You use either acyclovir or acyclovir or famciclovir, so that is a must. And here we have I'm not sure. This is CMV. Patients treated, yes. CMV prophylaxis is not recommended, but you may consider prophylaxis in patients who are seropositive. And here there's one recommendation from Fred Hutch. If you have a copy number of 150 or more, you may start CMV treatment or preemptive therapy, but that is unclear at the present time. Not everybody would follow this recommendation, and some of us, or many of us, would wait for clinical signs or higher copy numbers to start preemptive therapy. But it's important, if you have a patient, I think it's important to talk with your patient, there's no question, and ask him if the patient has sudden fatigue and reports about night sweats. It's always good to think about reactivation of CMV infection. And when you do a CT scan, you see these mid-class obesities, then you have the suspicion that there is a viral infection ongoing. When you do a biopsy, you find these giant cells with inclusion bodies, so then it's clear this patient has CMV infection and CMV disease and needs CMV treatment. Now, we have looked at the different recommendations, but you ask the question, what are individual centers really doing, and what is happening in individual studies? What was the case in CARTITUDE-1, one of the most important studies, because they showed this enormous efficacy of CAR T cells. And this is the data from the CARTITUDE-1 study. And when you look at this graph, you see almost everybody received antibiotic prophylaxis. Almost everybody received antivirals, which is clear. Of course, herpes viruses. Antimycotics were given to many patients, antiprotozoal to some patients, antimicrobacterials, probably to patients with a previous history of tuberculosis. But in a sense, what this table shows us, that in clinical practice, people try to be on the safe side, and we have to figure out what is the optimal way to move forward. And it depends, of course, very much on your patient's characteristics, on pre-treatment, and the present status, clinical status of your patient. So when you follow what shall you do during monitoring, it's a little bit unclear. There's no clear recommendation. But at the beginning, of course, you scan for all these viruses, no question. You want to exclude patients who have subclinical hepatitis, infection or disease. You want to exclude CMV. And so you do these pre-screenings, screening studies. And if patients develop any clinical signs, then you will start with more intensive diagnostics in order to figure out what's happening. But there are no clear recommendations how frequently this should be done, and probably it will be very difficult to come up with clear recommendations because it depends on the patient's situation. Some patients do very well without infections, so there's no need to do weekly or once monthly CMV testing. And in others who do very poorly, I think we have to be very cautious. Now, this is something, it's of minor, it's all relevant to a small number of patients. These are patients with active disease, active myeloma, and they come into close contact with somebody who has influenza or has active COVID disease. So you have some drugs available to protect those myeloma patients with active disease, with severe immune suppression, to get infected with influenza or with COVID-19. And I was surprised to see that this drug, I think it's in UK, it's given up for free to your patients. Where is it? Here, Paxlovid is probably available for every patient. Yeah. Now, Pfizer, of course, has decided to sell Paxlovid in the US, and the price is about $1,400 one package now. So we are happy here in Europe to be able to give it to our patients for free. So coming to other treatments, viral treatments of viral infections, I think EBV can be treated. You can use rituximab. You can use valganciclovir, which is active but not approved. You can, of course, use T-cell therapy. And I just point to RSV virus. You can use ribavirin, again, not approved in elderly patients. And adenovirus ribavirin is active but not approved in elderly patients. With bacterial infection, I don't go into much detail. The choice of antibacterial therapy depends on the situation. If the patient is neutropenic or not neutropenic, if the patient is neutropenic, you have to, and depending on his situation, if he's developing sepsis or close to sepsis, you need to use very active antibiotics like carbapenems, piperacillin, tazobactam. You may add fluoroquinolones if pneumonia is there, and vancomycin is reserved for very special cases because, you know, we are well aware of the renal toxicity, but in candida infections or with MRSA, it is still a very good drug. And of course, there's something which we call Sivoxid, which would be an alternative. Clostridium, we have now fidaxomicin in addition to these traditional drugs and so on. And with that saying, we'll come soon to my closure. We should not forget to provide optimal hygiene prophylaxis to our patients. And there's a recent report from the World Health Organization that they estimate that by using hand washing all over the globe, we would be able to reduce the mortality of about 1 million people. In hospitals and in private practice or wherever, of course, this is very important measure, and all the other measures which are listed here, particularly mouse rearing, but I won't go into this and would like to come to a closure. And these are some words of caution, because our evidence is really limited, and I already alluded to the differences of clinical trials, clinical follow-up duration, so it's not easy to compare one study with the other, in addition to the different patients' characteristics, pre-treatment, treatment, and so on. And we are lacking prospective randomized trials occur, and there's inconsistent reporting of infections. The recommendations in the literature are not completely consistent for all pathogens, and as mentioned before, prospective data of randomized studies are still have to come, but it will not be easy to do this. Now, but what we are all aware of, with BiTEs, as with bispecific antibodies and CAR T cells, we experience something which we have never seen before, namely this extremely high risk for bacterial and viral infection. And again, we see fungal infections in the minority of our patients, but it's a reality. There are manifold risk factors, as shown here. Prophylactic measures have been discussed before. I don't go into greater details. And we can hope for novel therapies. There are novel antibodies against certain pathogens which are in development. So we may have new drugs for treatment of infections with certain pathogens. You can use cytotoxic T cells, NK cells, and you can use allogeneic cytotoxic T cells in the future for special cases with treatment-resistant infections. And last not least, I think we should stay optimistic. Remember, 14 years ago, McElwain reported, I think, about 5 patients with multiple myeloma whom he treated with high-dose melphalan. And subsequent reports from him and Ray Powell's showed there is an enormous high infection risk because there was no G-CSF available. There were no stem cells available for stem cell transplantation. So I think our situation today is comparable to the introduction of high-dose melphalan 40 years ago. So I think this gives us hope that the intensive research, which is ongoing all over the globe, will help us and give us means to treat and to prevent infections more efficiently in the future than we are able to do it today. And with that saying, I would like to close and thank you for your kind attention. Thank you very much.
So thank you very much for an amazing talk, and thank you very much on behalf of the Society. What I was going to do is open the floor up for questions, and if there are anybody online that wanted to ask any questions, please do. So is there anybody in the audience that would like? I can see Gordon. Thank you.
Excellent talk, Heinz, as usual. Just wanted to gauge your thoughts in the post-immunotherapy space with cytopenias. Any thoughts about stem cell top-ups and their use to try and abrogate infection?
Any thoughts about stem cell?
Stem cell top-ups. So using stem cell aliquots that have been frozen from previous transplants to try and abrogate.
Yes. Of course, yes. That is done. Actually, that is done in few institutions. If you have stem cells on stored stem cells, if you have a patient with high risk with hematopoietic stem cell index high risk, with neutropenia, with aplasia, people try to use stored stem cells. I think that's a very good, of course, suggestion, and it's done, but I'm not sure whether it's very efficient, because you need a productive and supportive bone marrow environment. We are only looking at the stem cells, at the hematopoietic cells, but we have to assume that the supporting myeloid, non-hematological myeloid cells are strongly, let's say, handicapped as well. So I'm not sure whether that will help a lot, but it's done. Yeah.
Okay, I think we've got some other, so Rakesh, and then we'll come back to Faye as well. And then I'd encourage anybody in the online, if they want to pose a question, please do.
Thank you, Heinz, for that great talk. Our experience with bispecifics and the use of IVIG is indeed what you've shown, that is beneficial. However, our patients still are getting repeated viral respiratory infections. Any suggestions about how to overcome that, or do you think we should just lengthen out the dosing of bispecifics, which seems to have an improvement?
Yeah, Rakesh, you point your finger on a weak feature of the IVIG. IVIG is most effective against encapsulated bacteria, and it has significant weakness against several viruses. It may be beneficial, but not as much as against these bacteria. So, but we don't have anything, we lack alternatives, so we are doing that. And the question is, what is the optimal dose and interval? I think we are still in the blue completely. But probably trying to save your patient and to bring him out of this severe infection, probably sometimes are overdoing it if the system allows it, and we give high doses in short intervals. Yeah. Thank you for the question.
Okay, so Faye, and again, if anybody online wants to pose a question, please do.
So my patients find tablet burden very, very difficult. They're generally elderly patients, and they go from being very fit elderly patients, no medications, to me parceling them off back home with fluconazole, acyclovir, levofloxacin, cotrimoxazole, and then maybe 3 chemotherapy tablets, and they find it very difficult. So I wondered whether there are any future studies looking at particular subsets of patients that need certain drugs, because we used to reserve cotrimoxazole for those post-transplant, but I think COVID-19 made us all very nervous, and everyone now gets everything to prevent hospital admissions.
So maybe I didn't stress it enough in my presentation. It's very true what you mentioned. So we have, of course, and that is always what we are doing in clinical practice, we have to evaluate our patient and to have to evaluate the risks situation of those patients. I think antibiotic prophylaxis is not recommended for everybody. And I think this nice British study showed that the patients, the elderly patients with poor ECOG status, it was, were those who benefited most. So I think we have to select our patients, and we won't do this. We don't do this regularly in a patient who is fit, has no history of repeated infections. But there's something which is interesting, because you can learn from, we all learn from our patients. That is why we love what we are doing. So we did a survey and asked the patients how many infections did you have before the diagnosis was established. And half of the patients had an infection in the year before diagnosis. So, but there were some who had 2 or more, 3 or more, or 4 infections. So these are the best candidates. So it's not only the age, it's not only all the immune parameters, it's also patient's history. So I think we know what we mean. We have to consider different facts to come to the best possible decision, but still it remains, let's say, it comes to the art of medicine.
Thank you. Okay, so Stella, there's a question over here.
Do you think the doses of prophylactic immunoglobulin we're using might be higher than we need? I mean, if you look back historically, at the beginning when immunoglobulin first came in, we were giving 10 or 15 grams every 4 weeks to the CLL patients, and their lives were transformed. And several of the early studies just looked at 200 milligrams per kilogram, and they benefited from it. There was a significant drop in the number of infections. So I mean, gradually the dose has gone up over the years, and I suppose people will only ever want to do a trial with a high dose to ensure they've given enough, but maybe we're giving too much.
Yes, I'm not sure whether we overload the system, but of course it makes sense to see what is the required dose an individual patient needs. And you're completely right. But so these 40 grams are taken from, I think, treatments of patients with thrombocytopenia and so on. You may well benefit your patients with 20 grams every 4 weeks or whatever. So I think this is evolving. But coming back to Rakesh, because he was, of course, mentioning that IG is not an excellent drug for treating viral infections. Nowadays, the blood donors, serum donors, mostly have antibodies against COVID. And so, but the question is whether they have antibodies against the new variants, because convalescent plasma was initially, helpful, and these monoclonal antibodies were helpful, but now they are no longer helpful. So I'm not sure. So ideally, you should vaccinate your your blood donors for the most important pathogens, and see that your IV product, intravenous immunoglobulin product, really protects them against these pathogens. Yeah. Thank you.
So maybe we've got time for one more question, if anybody has any question. Yeah, we've got one at the back, and then that will be the last question. Thank you.
Thank you, Prof. It's really interesting about the vaccination schedule that you proposed there. Have you actually looked at the response of the patients with standard vaccinations? I mean, because most of our anti-myeloma drugs would target the non-malignant plasma cells as well. One of my questions in the head is always, how effective is this 2 doses, 3 doses of standard vaccination in those who are getting lenalidomide, Velcade, or other drugs?
So the question is, if I understood it properly, correctly, can we expect an immune response to vaccines? I think you depend again on the patient situation. You probably all see patients, and you follow patients who are in complete remission for years, and they have an obviously complete immune reconstitution. So they will respond. But the difficult to treat patients are those, and that is where you target your finger to, are those with active disease, with severe immune suppression. And so we are handicapped by the lack of immune response, or let's say impaired immune response. But considering that we have no other means to protect him, some of my colleagues, or of our colleagues, still opt for vaccinating those patients. Also, they are quite aware that the immune response is possibly not really very active, or there will be no response at all. So we have to live with that as long as this severe immune suppression is present in our patients. We don't have a clue to change it from one day to other. So I think that would be what we need, because we are all targeting on the myeloma cell, and there are few concepts which try to enhance the immune environment. But maybe in the future we will have more studies looking on the immune environment and changing the lymphocyte, the distribution of different lymphocyte subclasses. We need to reduce, when you, for instance, give daratumumab, you reduce the Treg cells, which stimulate myeloma cells. But that is obviously not enough. We need to develop more intelligent treatments. Yeah.
So thank you very much. So on behalf of the UK Myeloma Society, Thank you very much for delivering the Michael Morley. This is a gift on our behalf.
Thanks so much.
So thank you very much. So thank you very much to Professor Ludwig, an amazing talk. So just in terms of where we are now, so we're going to break for lunch. I'd encourage people to visit our sponsors. We're very, very grateful to the sponsorship that we receive as a society. So there is going to be the UKMRA Science Forum that will be in the Portland room. So they're going to start at 2 o'clock. And then we come back here for the main session, which is going to be the UK Myeloma Society AGM at 2:20, followed by patient quality of life and decision-making treatment. So thank you very much.